Assalamu alaikum, welcome to Start MRCOG. Today I will discuss the second part of intrauterine fetal death management. Perinatal post-mortem. Ample time should be allowed for this discussion and ensure the discussion takes place in a quiet, private place. Parents should be offered a description of what happened during the procedure and the likely appearance of their baby afterwards. This should include information how their baby will be treated with dignity. This is very important information, how to treat the baby with dignity, and any arrangements for transport, and that all discussions should be supplemented by the offer of written information. Importance of post-mortem should be highlighted, which could be helpful in management of the future pregnancy. In terms of information for subsequent pregnancy, when combined with other diagnostic tests, offer information relevant to the recurrence risk in up to 40% of cases and to management of next pregnancy in 51% of cases. Important information that affected management next pregnancy was elicited in 10% of stillborn babies with no recognizable cause of death from other clinical or laboratory investigations. The consent must be given for any invasive procedures on the baby, and the attempts to persuade the parents to choose post-mortem must be avoided. Parents should be offered full post-mortem examination to help explain the cause of late intrauterine fetal death, and if the patient refuses the full post-mortem, limited post-mortem examination which spares certain organs, non-invasive post-mortem and minimally invasive post-mortem should be discussed with the parents. Coming to placental pathology, independent of full post-mortem, placental pathology therefore should be offered even if post-mortem examination is declined, and it is very helpful in identifying a probable reason for the baby death in 11 up to 64.9%. Should be done by trained pathologists, and it is the single most useful aspect of evaluation of late intrauterine fetal death, and this could be a good question for single best answer questions in part 2. An MRI can be offered as a substitute for conventional post-mortem. If imaging is the only option, ultrasound and MRI remain the first line imaging. Time interval has been reported to be the most significant factor in acquiring a diagnostic quality post-mortem ultrasound study, owing to the tissue breakdown and the laxity of skull sutures. And MRI will be preferred to ultrasound scan if we suspect underlying cardiac abnormality or anomaly, or if more than 24 hours between the death and the birth. The National Preventive Care Pathway recommends a minimum of 1 hour should be dedicated for discussion regarding the post-mortem in a quiet, private place. The need to tell the parents if the post-mortem examination will take place in a different hospital and explain where and why. Parents should be offered a description of what happens during the procedure and the likely appearance of the baby. It should include information on how baby is treated with dignity and any arrangements for transport. Dignity of the baby is like a failure point in part 3 exam questions. All discussion should be supplemented by the offer of written information. We have SANDS website, and it is recommended that the consent form should include sections on the purpose of the postmortem, the extent of the examination, possible organ or tissue retention and the purpose, and what should happen to tissue and organs after postmortem, and research and education. Minimally invasive postmortem with laparoscopically assisted sampling has the potential to increase the diagnostic yield of less invasive postmortem by improving the quality and the quantity of tissue samples obtained, while permitting visualization, extraction, and examination of internal organs through a small incision, but will also depend on local skill and expertise. What are the options for the perinatal mortality review process and follow-up meetings? They suggested from practice, but not like evidence-based, to make the follow-up between 6 to 12 weeks after delivery. And all results of investigations, imaging should be available. So this period will be enough for that. They suggested also that if the parents came to the antenatal clinic, that could be distressing to them. So home visits or virtual appointments should be offered for the parents. Parents should be given a summary of the findings, and this summary should be discussed with the parents at the follow-up meeting or offered to be communicated with them, for example, by means of emails or posts. What are the content of the follow-up appointment? It should discuss with the parents who have late IUFD the following: chance of recurrence, any specific means of preventing further loss, general pre-pregnancy advice including support for smoking, healthy weight management, the conception timing, but this timing depends upon the parent and their wish, the possible reasons for IUFD, so it should be individualized. To discuss the possible reason for the intrauterine fetal death, this meeting should be documented in a letter, and this letter should include the outline plan for future pregnancy, non-medicalized jargons, using the name of the baby, send directly to the woman. Copy should be given to the general practitioner, and this letter should outline the plan for the future pregnancy. Clinicians can use also pro forma to aid preparation discussions during the meeting. What is the suggested or recommended subsequent antenatal care following late intrauterine fetal death? They found that the most important reason for recurrence is previous IUFD, with 4.8-fold increase in the risk of late IUFD. In case of intrauterine fetal death due to placental dysfunction or unexplained cases, the following care should be offered: obstetric-led antenatal care, emotional and psychological support for the parents, fetal biometry and amniotic fluid assessment, in addition to Doppler flow velocimetry with umbilical artery Doppler were appropriate at minimum every 3 to 4 weeks from 26 to 28 weeks of gestation. They found that low CPR, cerebroplacental ratio, values in the third trimester of pregnancy have shown to be an independent predictor of late IUFD and perinatal mortality. Because FGR is 2 to 3 times more frequent in women who had late IUFD, then they will screen for the fetal biometry. And recommended to give low dose aspirin between 60 to 150 milligram starting from 12 to 36 weeks. They found it will reduce the risk of IUFD and growth restriction. In addition, other measures like screening for GDM in unexplained late IUFD, or if there was signs of macrosomia on the baby or placental findings consistent with glucose dysmetabolism, such as delayed villus maturity or fetal vascular malperfusion, and women shouldn't be screened. They found that women who was not offered screening for GDM have 44 higher risk of late IUFD. When a reason is found like antiphospholipid syndrome, they found that the woman will benefit from low molecular weight heparin, but it shouldn't be given like a routine in unexplained cases. Modifiable risk factors like high BMI above 30, poorly controlled GDM modification is helpful, and when no reason in unexplained cases, treating the pregnancy like placental reason may improve the outcome in subsequent pregnancy. It is recommended to induce the labor by 39 weeks, which is not associated with increase in the risk of cesarean section, assisted birth, fetal morbidity, or admission to neonatal intensive care. They found that perinatal death and other adverse events were 4.4% with induction of labor group and versus 5.4% in the expectant management group. Earlier birth may be considered for women and pregnant people with earlier IUFD, cholestasis, preeclampsia, insulin-dependent diabetes, and other maternal risk factors, including psychological consideration, and the decision is always a risk-benefit balance with prematurity of the baby. So this is regarding the timing. Regarding the mode of birth, there is no data confirming that role of cesarean section in reducing prenatal mortality and morbidity or maternal psychological morbidity. So planned cesarean section should be informed decision making with the woman. So until now, the recommended will be to do to do induction of labor around 39, and it could be earlier if the patient has any comorbidity. The last point in the IUFD is the clinical governance issue. Risk management standards they set or suggested. So the maternity units should ensure that they are tracking their outcomes and benchmark against other organizations. So they will benchmarking means that they will compare their current outcomes with the outcome in standard in the other hospitals. They put standards for standard checklists for documentation to ensure that all appropriate options have been offered to the woman. And consent for post-mortem should be documented using nationally recommended form. All stillbirths should be discussed in multi-professional meeting using standardized BMRT to ensure lessons are learned from each IUFD and shared widely. And all stillbirths should be reported to the Embrace National Maternity and Prenatal Audit PMRT database, maternity and newborn safety investigations, MNSI, or research studies in bereavement care or evaluation of bereavement services for stillbirth should consider the use of developed core outcome set for stillbirth care to assess the effectiveness. Thank you for watching. I hope it was useful for you and wait for the next video.